usually like to begin these topics and these talks. These are all complex topics. And I'm showing you, I like to show unknown cases in the beginning. And the intent of showing these unknown cases is for us to recognize the challenge when we are faced with these kinds of infections, right? They're all infections, and notice that there is a common theme here. They all involve deep gray nuclei. And when we talk about deep gray nuclei, we mean basal ganglia and thalamus. And next week, I might show this slide again because the theme of next week's talk is bilateral basal ganglia lesions, bilateral thalamic lesions, toxic metabolic lesions, and they all look very similar. So I will give you more practical tips of how to differentiate between so many of these, which look fairly similar, right? As you are seeing already in this case. And guess what? One of these 4 patients actually had COVID. And they were scanned, she was scanned during the peak of COVID, and very first time when we did an MRI scan for a COVID positive patient. This was, a few years ago. So I'll discuss those findings also. Now, as Alex said, one of my passions is to travel and to teach and to learn at the same time. And a few years ago, as part of ASNR. ASNR is American Society of Neuroradiology. And so Anne Osborne, if you all may have heard about Anne Osborne, right? She is known as mother of neuroradiology, right? The famous Osborne textbook. So she has started Anne Osborne International Visiting Professorship. And I was very privileged to have had that opportunity. And, I was the Anne Osborne professor, and I was sent to Cape Town, South Africa. And my goal there was to teach and train radiologists in that country. Anyway, so while I was there, one of their residents and fellows, they actually showed me this case. So this is an actual case from a different country. And, I was looking at this case, and I will tell you what I thought this would be. And again, I was wrong. And then a few months later, they sent me an email with the actual pathological diagnosis for this case. So think about this and see if, you all are radiologists. If you have something like this in your practice in Armenia, like what would you think and how would you describe, and, what kinds of differentials will you present in your report, right? Now, here is case number 3. So case number 3, and, again, a young man, 24-year-old, presenting with long-standing headaches. Like I'm showing you a whole bunch of sequences. Again, think about that, if you are the radiologist who is asked to interpret this study, like how will you describe these imaging findings? Like what will you say in your report, right? And I'll show you the answer to these cases towards the end of this talk. All right, now to make some salient points, to make some very, very important points, in the theme of this imaging of CNS infections, I will show you this index case. And I will show you this index case, and I will tell you what were the mistakes that were made. This is a normal head CT, right? A head CT, a non-contrast head CT. This is a 79-year-old, an older person who was transferred to our ED. ED is emergency department, from a nursing home, right? And the only history we had was altered mental status, right? And the radiologist who was on call at 4 o'clock in the morning, right? At 4 o'clock in the morning, they looked at this case, and all they said was that there is some ventricular prominence, right? And they did say the ventricular prominence looks like it is out of proportion to the sulcal prominence, right? The sulci are not as big, the ventricles are bigger, right? In an older person, you would think about what? Normal pressure hydrocephalus, right? And this is exactly what they said. Looks like this is an older person, non-specific mental symptoms or mental status changes. And there is ventriculosulcal discordance, correlate clinically for NPH or normal pressure hydrocephalus, right? So that was the report at the time. Now, patient kept on deteriorating. They kept on declining. And a few hours later, right, I have the date and time, they came back for a repeat head CT, right? Came back for a repeat head CT in a few hours, right? And the person who was looking at this head CT, there is, we all are very busy. And, when we get a normal-ish looking scan, the intent is to read that quickly, right? So you can save time for more difficult cases, right? So again, the person who was looking at this case, what they did was they just cut and paste the previous report, right? And they glanced at the imaging finding. They said, no real change. Basically, the same report was given again, right? Given again. Now, this is the scan a few hours later, right? The patient kept on deteriorating. Now they are posturing, right? And so they came back again, now this time for an MRI scan, right? This time for an MRI scan, right? Everybody sees the findings, right? There is massive, right? This is not a T2 scan. This is a flare scan. Notice the ventricles are dark on the sequence, right? This is a flare scan. And notice that the sulci, right? The sulci, they appear so hyper intense. The CSF in the sulci is not suppressing. And notice this is post-contrast T1, right? And there is extensive enhancement. This is also a post-contrast T1. And there is extensive increased signal in the cerebellum, bright signal on DWI, restricted diffusion. And notice here, what is this happening, right? Tonsillar herniation, right? Tonsillar herniation, and what? The patient passed away a few hours later, right? So the story here is that everything from start to finish, they were okay, like, 127, 4 o'clock, right? Relatively okay. And then in a matter of what, less than 12 hours, they passed away. So the point is that, if these findings were made early on accurately, then we may have been able to save this patient's life, right? So how quickly these infections, they progress. And this is a case of presumed viral meningitis, right? Presumed viral meningitis and devastating. So why are these important, right? These are life-threatening conditions, right? These things cannot wait. We have to stop everything. If we suspect there is an infection, if we suspect there is meningitis, we stop everything, we make a phone call, right? These are increasing in incidence, right? And prognosis depends on how quickly we can identify these imaging findings. How quickly can we make the right call, right? This is just non-contrast head CT, right? We'll talk more about the imaging findings in meningitis as we go along. Here is the second case, right? This is the second case. And this case was actually read by, a resident who was as bright as Michael, who is with us today, right? They were looking at this case and they picked up all the findings. And what are the findings? The findings are that if you look at, this is again a 32-year-old person, right? Not very old, not very young, right? So now the sulci at the top of the brain and the rest of the brain cisterns, they all look diffusely effaced, right? Diffusely effaced. So, when I show these kinds of things, when I teach our trainees and residents, one thing I say that no matter how young the patient is, you go to the very top of the brain on the axial section, and you should be able to see 3 sulci on each side, right? And, I call this 3 sulcus sign. Like, and Michael was with me yesterday, I was telling him these things are not described in textbooks, right? These are life lessons, right? These are not described in textbooks. And if you don't see 3 sulci at the vertex, then no matter how normal that scan looks, you cannot let that go, right? This patient has diffuse brain swelling. This patient has diffuse cerebral edema, right? So that becomes life lesson number 1 when we are dealing with a head CT, and there is a question of infection, right? So this was called, believe it or not, by one of our residents, right? And patient was started on an antiviral therapy, and this was presumed H1N1 pneumonia and H1N1 meningitis, and patient was discharged, right? Right. So with this background, the objectives for this.
Suyash, can I interject one thing?
Sure.
I had to say something. I've been in practice 40 years. I've never heard of that sign, but it's brilliant. And I really commend you for bringing that to our attention. And for all of the radiologists, I just wanted to point out that the value of this sort of format is that a lot of the finesse aspects of neuroimaging are not things you find in textbooks. So I admire you, Suresh, for bringing that to our attention. And here I am, the old guy. I learned something. Thank you.
No, thank you very much, Alex. I have learned so many things from you. And I think about you and your teachings every day in the reading room. I've said that many times before. And Michael was with us yesterday, and we had a similar case, right? A similar case. And I let Michael read that case and make the phone call. And when he called the ICU, they told Michael that patient has no corneal reflexes, right? Exactly the similar case, but it was a little late by the time we made that phone call, and they were already talking with the family. So my point is that, as Alex mentioned, these things, or some of these things, many of these things are not actually written in textbooks, right? Which is why the value of these kinds of CMEs, right? The value of knowing people like Professor Mohan, who can, bring, one and one together, right? And so this is why we do this. And the other thing I was telling Michael yesterday, that, the value of apprenticeship, having good teachers around you. I must have learned this from somebody along the way, right? So which is why I'm kind of basically transferring this knowledge over to all of you. All right, so now the role of imaging in the realm of infection is multiple things that we have to look for. Now, I start with meningitis because meningitis is the most common CNS infection. Now, when we think about meningitis, there are so many practical issues. I know you all are fully trained practicing radiologists, right? So my goal here is not to teach you things that are in textbooks. My goal here is to teach you things that are of practical importance, right? We deal with these questions all the time, right? And what I mean by this is that when you have a post-contrast, let's say post-contrast T1, there is always this question, is this normal meningeal enhancement, or I'm seeing normal cortical veins, or is this meningitis? Like, how do I distinguish between that, right? It comes to our mind all the time. Now, we say meningitis. How do we tell that this is acute meningitis? Is it chronic meningitis, right? What are the imaging signs to make that distinction? We all think about meningitis as infectious. There are inflammatory causes of meningitis. And I've asked Michael to show you some inflammatory conditions of meningitis. So he'll discuss pachymeningitis with you. How do we, besides infection, inflammation, right? There are neoplastic causes of meningitis, right? Carcinomatous meningitis. How do we distinguish that? And there are so many imaging clues, we'll go over those. Then if meningitis progresses, it can cause brain abscesses, right? And we'll talk about brain abscesses. Brain abscesses can be, again, of different kinds. It can be bacterial abscess, right? Pyogenic brain abscess. Then you can have a fungal abscess. You can have a tubercular abscess. Like, many of these will look similar on imaging, but how do we distinguish between these, right? So I will teach you those things. Now, there are certain tumors that can look like infection or an abscess. I'm talking about cystic tumors, right? How do we say that, we are dealing with a cystic tumor and this is not an abscess, right? We'll talk about that. Then there are certain infections, this category of atypical infections, which are commonly seen in patients who are immune compromised, right? There can be dual pathology. You have one problem, and then you have infection superimposed on an existing problem, right? How do we deal with that? And I'll show you those examples. And towards the end, I'll kind of wrap it up and show you some, common things and themes that we saw during this recent, or maybe ongoing COVID pandemic, right? So most common CNS infection is meningitis. Now, I've always said that what is our role, right? Our role is not necessarily to confirm, not necessarily to diagnose. Like, many a times the imaging may not show much, right? Our primary goal is to look for complications. And even important thing that we have to do is to rule out increased ICPs, increased intracranial pressure, before performing lumbar puncture, right? Again, this is something that comes to us all the time, right? You will get a phone call that, can I do lumbar puncture in so-and-so? right? So my response to those kinds of relations is that, well, that's not my job to decide. You have to decide, can you do or not? I will tell you if there is any increased intracranial pressure or not, right? Then it is for you to take the call that if you want to do it or you don't want to do it. Now, when you see meningeal enhancement, it can be from a variety of causes, right? Variety of causes besides infection, tumors, it can be reactive, right? We see post-op enhancement all the time, right? It could be chemical meningitis, or again, inflammatory conditions that we will show you some cases towards the end of this talk. Now, the other major point that I'm trying to make here is that in many circumstances, meningeal enhancement that we see on imaging is non-specific, right? You see enhancement of the meninges based on their location. You can suggest etiologies, we'll go over those. But by far, this enhancement is kind of non-specific. And when your T2, when your FLAIR scan starts looking like a T2 scan on the cell side, that means you're dealing with diffuse meningitis, right? Again, that is another important sign, and this is known as FLAIR sulcal hyperintensity. Besides infection, besides meningitis, there is a differential diagnosis for this, right? And again, I recommend all radiologists to have this list of differential diagnosis in your back pocket, right? And I will show you how to do that, how to memorize those things in one of these slides. Now, here comes, life lesson number 2, right? How to differentiate between normal meningeal vessels and abnormal leptomeningitis. Again, I love both of those people. So Doug Quint was my attending when I was doing my fellowship, right? And he published this. And again, when you read all these papers, you won't find, this is distilled information from all of those articles, right? And this Dr. Kamra, he was 1 year ahead of me in medical school. So I've learned a lot from both of them. So this is, the summary of what I learned, right? The summary is that abnormal enhancement is usually thick, right? It is nodular. It is asymmetric. It goes to the depth of the sulcus. And the most important teaching point is that when you scroll through your axial post-contrast T1 weighted images, if this enhancement persists on multiple axial images, it is abnormal. Now, when you think about the subarachnoid spaces, right? Think about the space where you have leptomeningeal enhancement. What normally runs in those spaces? Like you have normal cortical veins and you have normal meningeal arteries and meningeal veins. They are very fine, small tubular structures. The point is that they will not persist on multiple axial images, right? I'm not talking about 3D acquisition. I'm talking about regular 3, 4, 5 millimeter, regular, spin echo, post contrast, T1, that kind of images. So if this persists, it is abnormal. If it goes down to the depth of the sulcus, it is abnormal. If it is thick, if it is nodular, if it is asymmetric, it is abnormal, right? So that is how we distinguish. Now, here is, the next, teaching point. Like, how do we differentiate between acute meningitis versus chronic meningitis, right? Chronic meningitis, we think about TB meningitis, right? Tubercular. Chronic meningitis, we think about fungal meningitis. These patients, the abnormal enhancement is usually seen at the base of the brain, right? This is basal meningitis. Whereas in acute meningitis, enhancement is usually present along the convexities of the brain, higher up, not so much at the base of the brain. And again, this is what I meant when I said the enhancement goes to the depth of the sulcus, right? It is present on multiple images. So this is how we distinguish between acute and chronic meningitis. The next thing, how do we distinguish between infectious meningitis and neoplastic meningitis? Now, tumor meningitis, lymphoma causing meningitis, leukemic meningitis, all these things, you will find some degree of dural enhancement, some degree of pachymeningeal enhancement, as I'm showing you. In this case, who had a proven leukemic meningitis, right? Leukemic meningitis. Now, this is also, a very illustrative case, a somewhat sad case. This young person was a very, very bright software engineer who used to work for Microsoft, right, in Seattle. And he actually is the cousin of one of our attendings, one of our faculty in neuroradiology here at Penn. So Seattle is on the West Coast. He was visiting them during a holiday, and he felt abnormal. He was dizzy. He had a fall, so he underwent this MRI scan, right? And if you look at this MRI scan, nothing obviously stands out, right? This looks pretty much like a normal study, right? Since he was coming with some dizziness and imbalance, we did some additional IAC, right? Internal auditory canal, IAC type sequences. And now this finding was picked up, right? And you see some enhancement in the IACs. And again, believe it or not, the person who was reading this case, very bright person, they picked up this finding and they said there is nodular enhancement in the IACs bilaterally, correlate for stigmata of NF2, neurofibromatosis type 2. But this is a software engineer. There is no NF2, right? What are you talking about, right? And then believe it or not, 3 months later, they passed away. The point is that this patient had carcinomatous meningitis from colon cancer. The point is that anytime you are looking at an MRI scan and you have history of primary cancer, and your job is to rule out metastasis, right? We do that all the time, staging MRI scans. Make sure you have cleared the IACs. This is the very first place where you can have leptomeningeal enhancement and carcinomatous meningitis, right? So that becomes life's lesson number 4 or 5. Now, many of those things we described in this manuscript almost 10 years ago, right? 10 years ago, and this became kind of very popular because, we as practicing radiologists, we know what do we not know, or we know where do we struggle. We know what are the problems that we face, and all of those things we described in this paper. It became one of the most read papers of neuroimaging clinics of North America. And 10 years later, they asked us to rewrite this manuscript, right? 10 years later, they asked us to rewrite, and this finally came out a few months ago. And notice that this is Michael Duong, and he is with us today. And he will illustrate several other, things and findings and cases that we discussed in this paper. And if you all are interested, let us know. We are happy to share a copy of this with all of you. Because, all these things that I'm talking about, right? This is the box I was talking about. And this is something that we have to keep in our back pocket all the time, right? When you have increased signal on FLAIR scan, right? Besides meningitis, what else can it be, right? These are the things it can be. So you have to go through this list every single time to give the accurate differential diagnosis for that particular case. Now, when we think about imaging in meningitis, the most common imaging finding is what? Is a normal scan. Now, over the years, as Alex was saying, he's practicing for 40 years, and I think I'm practicing for over 20 years myself now. And I'm now beginning to realize that if you look carefully, the scan may not be normal in some of these cases. And what I mean is that, you have very subtle sulcal effacement, right? Which is why when you go through these head CTs, train your eyes to pick up those subtle asymmetries, right? Always compare, if you have a prior study, compare if the sulci were seen better on the prior study and now they are effaced, right? So that is not a good sign. As we age, the brain does not gain volume, the brain loses volume, right? So the sulci should become more prominent over time. And if they are going in the opposite direction, then you are suspicious. Now, the other thing that you have to think about is that, as I said earlier, the role of imaging and our role is more to look for complications of meningitis, right? And I will show you several of these complications along the course of this talk. Now, in kids, particularly who present with viral meningitis, you will see that these are exudates. Notice that this collection outside, these are subdural exudates that do not suppress, that do not completely suppress on FLAIR, but they do not restrict. right? This is a typical example of subdural effusion, right? Subdural effusion. And if you are astute, you might notice what is that? This is a small focus of cerebritis. Now, if these collections become infected, in those circumstances, these subdural collections will begin to restrict diffusion, right? And that is what we call as subdural empyema, which is a neurosurgical emergency, right? Neurosurgical emergency. So how do we differentiate between effusion and empyema? Diffusion restricts in empyema and does not restrict in subdural effusion. Now, if this empyema is outside the dura mater, right? This is a post-op case. You notice this craniotomy here, right? And that is the dural reflection, right? And this collection is outside the dura, restricts diffusion. Notice how black the signal is, how dark the signal is on ADC. This becomes an extradural or epidural empyema. Now, if the pus or infection extends into the ventricles, right? It becomes, again, this is layering debris. Notice there is a rind of increased signal along the margins of the ventricle, along the ependema. So this is ependymitis, ventriculitis, hydrocephalus, layering pus or debris, another complication of meningitis. Now, this is also, a relatively sad case. And, I was telling Michael about this yesterday, that she's actually the wife of one of our ENT surgeons, right? One of our ENT surgeons. And all she was complaining of is headache. And she had known sinusitis. So notice that, this sinus infection extended into the orbit. You have pre and post septal orbital cellulitis, right? And this extended into the brain. And what it did was it thrombosed the anterior part of superior sagittal sinus. And she presented with extensive bifrontal venous infarcts, right? I think she was only 34 years. This is a few years ago. And she's alive, but several deficits, right? So just complication of sinusitis extending into the orbit and extending into the brain, right? Now, the other complication of meningitis can be, or any kind of brain infection can be, a brain abscess, right? So diagnosing brain abscess is usually not difficult for most of us, right? Because, the teaching is that anything that restricts, any ring enhancing lesion that restricts, right? You see the ring enhancing lesion, or, again, if Dr. Mohan might say that, this is bigger than a ring, so we should call it peripheral enhancing lesion, right? Ring is like, that goes to your finger, right? Peripheral enhancing lesion with central restricted diffusion should be considered a brain abscess unless proven otherwise, right? The next thing is that, spectroscopy is very helpful. Again, I understand that, you all may not be doing, but in case you are doing, then you look for this peak of acetate at 1.9. If you can find that, then it is, again, very helpful to look for to diagnose a brain abscess. Now, next important teaching point is that how do we differentiate a cystic tumor from a brain abscess, right? So two things. Number one, as I said earlier, if you have access to spectroscopy, you look for these two peaks, acetate and succinate, right? 100% specific for a brain abscess. The second thing you look for is presence of restricted diffusion, right? So in abscesses, you have restricted diffusion, and in brain tumors, usually there is facilitated diffusion, right? So these two features help us in discriminating between a brain abscess and a tumor that looks like a brain abscess. Again, this is the differential diagnosis for ring or peripheral enhancing lesions, something that we have to keep in our back pocket. Okay, so I've shown you a diffuse form of TB, right? A case of tubercular meningitis. Now, TB can present as localized infection, right?
So Yash, can I interrupt for one moment?
Sure.
So I don't know if you're going to talk about that, but one of the problems I have encountered in determining if the FLAIR scan is abnormal is in cases of young people where they frequently have very little subarachnoid space over the hemispheres. And so it can be difficult to tell if his sulcus is absent because the brain is doesn't allow much filling of CSF around the hemisphere, and when it's filled with some debris or protein, which is why it's not suppressing on flare. So I don't know if you've had experience with this, but what I like to do is on PACS, I reverse the contrast on the T2 weighted scan. I link the images with the theory that every sulcus I see on the T2 reversal image that is dark, I should see on the flare scan. And whenever I see a mismatch in those two, and oftentimes it's subtle, it can be in the occipital region, can be in the subfrontal region, that I usually will say that's abnormal. And you can see that finding in some patients before the enhanced scan is abnormal. The other thing, though, the other trap, though, and coming back to your point of why we're not the primary diagnostic tool, is that until the protein gets to about 100, the flare scan can still be abnormal. Anyway, I just wanted to mention that because I found that to be helpful in my practice.
Now, again, I appreciate that. And this is something that I learned from you on the workstation. And again, another, valuable tip that is not mentioned in textbooks, right? So again, everybody should recognize that. And if you want to see how this is actually done, I would encourage you all to ask Professor Mohan to actually show you how to do that, because until you see it with your eyes and how do you invert and how do you link and how do you see it, it is somewhat difficult to understand this concept, right? So at some point you should ask them. I'll ask him to show you that. All right, so moving on. So localized infection of TB can be in the form of a tuberculoma, which is very common, or it can be a tubercular abscess. If the signal on T2 is very dark, then it is most commonly a tuberculoma, and usually in these patients, the diffusion signal is not restricted. And if you do a spectroscopy, you will see a prominent peak of lipid. Another example, dark signal on T2, and this was also a path-proven tuberculoma. Now, tubercular infections can spread hematogenously, right? And this becomes a case of miliary tuberculosis. Again, keep in mind that, metastasis is always going to be the differential, so you have to look for underlying primary, etc. Now, if the central signal on T2 is hyper intense, and notice now it is restricting, this is how we diagnose a tubercular brain abscess. Now, another example of the kind of abscess that has very unique imaging features, is this example. Now, I'm showing you this T2 scan, which has this irregular frond-like things that seem like they are arising from the wall and they are projecting inwards towards the cavity. Notice that the wall enhances, but these projections do not enhance. Notice that the wall and the projections, they all restrict, right? Very typical. Another example, wall, all these frond-like projections, right? Do not enhance, but they restrict, right? This is a classic imaging finding of a fungal abscess, right? So you diagnose fungal abscesses by these findings, these frond-like projections. They do not enhance, but they restrict, and this is how we diagnose a fungal infection on imaging. All right, now HIV can present with variety of things, right? Variety of things. I'm showing you this patient with multifocal narrowing irregularity bleeding, right? This is a case of HIV vasculopathy. And this is just another simple thing that HIV can also present with just red eye, right? Red eye, or just looks like conjunctivitis. Now, HIV, if it affects the brain, it may involve the deep gray structures. And this is a case of HIV meningoencephalitis. And on follow-up, there is some improvement of many of these abnormal imaging findings. Now, in patients with HIV can also present with a lot of opportunistic infections, right? Most common fungal infection, which is seen in patients with HIV in the brain, is cryptococcosis, right? Cryptococcal meningitis. Classic imaging description, something that we should always remember. Another practical life lesson is that if you have symmetric appearing enhancement, symmetric or asymmetric appearing enhancement along the perivascular spaces in the basal ganglia, in an immune compromised patient, right? There is only one diagnosis, which is cryptococcal meningitis or cryptococcosis. These patients can present. So this is an example over here where the enhancement along the perivascular spaces was unilateral, right? Nothing on this side. This is difficult. This presented with meningitis, focal meningitis. This presented as a giant mass, and this was actually confused for a GBM, right? So this and this is difficult, but something like this and the previous case, bilateral symmetric appearing enhancement, should be easy to diagnose. Another, opportunistic infection, which also presents more commonly in patients who are immune compromised, is toxoplasmosis, right? Toxoplasmosis, again, notice these multifocal, irregular, hemorrhagic, lots of edema. Notice there is no diffusion restriction. These patients are severely immune compromised, right? When they are so immune compromised that these toxoplasma abscesses, the pus is not viscous enough. The pus is actually very watery because these patients, they are not able to mount an immune response, which is why the diffusion becomes negative. The other point is that in these toxoplasma abscesses, some lesions might restrict, some may not restrict. So if you see this kind of pattern of very irregular findings on diffusion, susceptibility on gradient, or this infolding, eccentric infolding of the wall on these post-contrast images in the form of this, what I describe as an eccentric target sign, which is not very common, but if you have it, then it becomes a very useful diagnostic clue to diagnose toxoplasmosis, right? Toxoplasmosis. Now, the most common parasitic infection that is seen worldwide, right, is what? Neurocysticercosis, right? And I'm showing you this case of neurocysticercosis, another example where the cysts are somewhat bigger in size. Now, if we suspect that this could be a case of neurocysticercosis, then we have to do two things. Only two things help us diagnose with some degree of confidence that yes, we are dealing with a neurocysticercosis case or a cysticercus cyst. Number one is that we should be able to demonstrate the scolex. And for us to be able to demonstrate the scolex, we have to do a high resolution T2, CIS, Fiesta, Drive, Restore, whatever sequence you want to call it, right? High resolution T2, heavily T2 weighted sequence to look for this eccentric scolex. The second thing that we need to do is, if we have the capability of doing spectroscopy, then we do spectroscopy and we look for peak of succinate at 2.4, which is also diagnostic for a parasitic cyst, right? So these two things. Now, sometimes these cysts can be intraventricular, right? Intraventricular. And this is a case of a neurocysticercus or a cysticercal cyst. Notice you can see these cyst walls in the fourth ventricle, right? And this is intraventricular neurocysticercosis. Now, Alex, take a look at this case. This is a case that I like very much because, this is like, I think a few years ago now. She is the mother of a famous neurosurgeon in New York, right? And so she presented with one episode of seizure. And while she was visiting her younger son or daughter somewhere in New Jersey, closer to Penn. So when she had the seizure, her son asked her mother and her parents, whatnot, to transfer her over to our hospital. And so she comes here and she gets the scan, and whoever did the scan, they saw these lesions and they saw the edema, and they called it metastasis. And so the neurosurgical team was activated and she was all set to go to the OR. the next morning, right? And so for these kind of new tumor diagnosis cases, we get all these kinds of spectroscopies and CBVs and all the advanced sequences. And I was looking at it, I saw something, and I called the surgeon. It was Dr. Brem. I said, Dr. Brem, I don't think that this is meds. I think you should cancel your OR, right? I think it is a parasite. So, when you call the surgeon, a senior surgeon, and you call them that you cancel the OR, nobody likes that, right? Because then they all said, what are you talking about? And anyway, so, finally he agreed, and, a bunch of tests were done. And, this was, she was started on anti-helminthic, right, anti-parasitic treatment. And this was eventually confirmed to be neurocystic sarcosis, right? Neurocystic sarcosis. Again, something keep in mind that succinate P, if you can show this, that becomes in such a small lesion, right? If you have good quality spectrum, you can still do it. And we were able to show that and prevent an unnecessary craniotomy for this case. This is a case which was sent to me from Mayo Clinic, right? And look at this, right? This was actually called a colloid cyst. Colloid cyst, right? It is in the third ventricle, asymmetric ventricular obstruction, hydrocephalus, right? But what is the clue? That's the clue. And look, this is what came out, right? Another case of neurocystic sarcosis. Now, I will be going to Tanzania. Actually, this morning I was, getting as part of an RSNA assignment to Tanzania, and I was looking up, and then I found this. Like, look at this. These are all these, tinea multiceps, which happens in animals, right? And all these parasitic cysts, and that's how they look like, right? In the brain of a goat. Now, I was talking about, dual pathology, right? Dual pathology, and this patient is, a known case of metastatic breast cancer. All kinds of treatments have already been done. They now came in with new onset of seizures, right? And again, this is a great call, which was made by one of our fellows, right? You can see all these enhancing lesions, right? These are all different meds, right? But when you come here, this was a change. This finding was not present on the prior MRI scan from a few weeks ago, right? And she came in with new onset of seizures, right? It's not status epilepticus. Notice that this is extending into the inferior frontal, and notice that there is diffusion restriction and patchy areas of post-contrast enhancement. And he rightly called this that, I'm very concerned. This is what? HSV encephalitis, right? Herpes encephalitis. And this was proven, right? Very soon, in a few days, CSF was done. They started acyclovir, and now this patient is actually doing okay, right? The importance of making the right diagnosis in a timely fashion, right? Viral encephalitis, HSV encephalitis. It can be symmetric, it can be asymmetric, it may enhance, it may not enhance, it may have hemorrhage, it may not have hemorrhage. Notice there is classic sparing of basal ganglia, right? Lot of other encephalitides, viral encephalitides, they involve the deep gray nuclei. This is one that spare the deep gray nuclei, another teaching point which you may not find in textbooks. All right, next case. Now, if you have symmetric appearing abnormal signal involving the mesial temporal lobe, right? Then you think about HHV6 encephalitis. Again, this is increasing in incidence. This is most commonly seen in patients who have undergone solid organ transplantation, right? So again, keep this in mind, because acyclovir may not work in this kind of encephalitis. Now, if you have involvement of bilateral thalami, you think about flavivirus encephalitis. And these are two flavors of the same virus. Japanese encephalitis, more common in Asian countries. And this is West Nile, which is more common in Pennsylvania or in North America, right? Now, another encephalitis that typically affects the thalami in a very classic type of distribution, right? This is called trilaminar pattern, trilaminar hemorrhage, trilaminar hook-like appearance, susceptibility in the thalamus in a young patient or relatively young patient is diagnostic for acute necrotizing encephalitis. Now, this became very popular, and this was the very first case of COVID that came to North America. She was an airline crew member, air hostess in Delta Airlines, right? And she came from Italy to Detroit in Michigan. And she was found down, and and this is what they found. And this was one of the very first descriptions of COVID-associated ANEC, which was published in radiology. And ever since then, we have seen, a whole bunch of different imaging findings. And I particularly like this one because we were the ones who coined this term. And the term that we coined was COVID-related disseminated leukoencephalopathy, or CRDL. Like we talk about ADEM, like ADEM and MS. So this is something that we were the first ones to describe this in patients with COVID, and this was CRDL, or COVID-related diffuse leukoencephalopathy. Now, COVID, we have seen, presents with all kinds of infarcts, right? Small vessel infarcts, large vessel occlusions, hemorrhages, small, multifocal, bilateral. And this is the case of, COVID-related encephalopathy that I was mentioning earlier. It can present with cereballitis. It can present with pontocereballitis. It can present with tumefactive demyelination. It can present with anosmia, right? And there was discussion about enhancement of the olfactory bulbs. It can present with Guillain-Barré syndrome, or GBS, right? It can present with this very interesting presentation of COVID, is these very sick ICU patients, when they are intubated for a long time, they have this cytokine storm related injury to the corpus callosum. And imaging findings in these patients, it mimics Markia fava bignami disease, right? Very typical, right? Notice that the restricted diffusion, swelling, and this appearance of corpus callosum is very typical. And this is seen also seen in patients with COVID. All right, so now towards the end of this talk, right, I showed you these 4 unknown patients. And if you remember, this patient number 4 was actually HIV encephalitis, right? I showed you earlier. Now, I'll spend a few minutes on patient number 3, because patient number 3 became like a diagnostic dilemma for all of us, right? So this is how she came. And notice the date. This is 28th of July. And then a few weeks later, and then again 5 days later from here, she passed away. And during this time, we did multiple MRI scans for her. And notice that the imaging finding continued to progress. And this is how she presented. Nobody was able to make this diagnosis, right? And this diagnosis was made actually on autopsy. And this is a recent case from here. And she died of rabies encephalitis, right? Rabies encephalitis. Again, very typical and striking imaging findings. This is, patient number 2, right? And notice there is this increased signal in the left caudate, bilateral lentiform nuclei, right? And the clue here was that this 15-year-old presented with these tiny spots that look like this, right? I always say that, we have to use all the information that we have. In this case, this was the clue, right? This was the clue. And these were classic what? Koplik spots of measles, right? And this patient has measles encephalitis, right? And this is what measles does to your brain, right? And this is known as subacute sclerosing panencephalitis. Now, finally, patient number 1, this is how, she came to us. Again, this is very early during the COVID pandemic. And notice that, she was poorly controlled diabetic. HbA1c, believe it or not, was 17.4, right? When she came to the ED, her saturation was 49%, right? And she was walking, talking, and people were not able to believe it. So they changed multiple pulse ox on her and to confirm. And then the second one was actually 47. So this is what we learned about happy hypoxia, right? And this is her chest X-ray, COVID pneumonia, and then she presented with this, right? And this is a case of, again, hypoxic injury to the basal ganglia in patients with COVID-19, right? In patients with COVID-19, right? So these are the 4 unknown cases that I showed in the beginning. Now, this case from South Africa, and Michael, I'll leave a few minutes for you. And so, when I was looking at this case, this is obviously very irregular. Looks like there is some susceptibility around it. There is some enhancement of this wall. And I was thinking that we are dealing with a pilocytic astrocytoma. That's what I thought. And guess what? A few months later, when I got an email back from them, this turned out to be another parasitic cyst. Now, lessons learned for me. Lesson number one, I've been teaching you, look for Scolex, and I did not follow what I've always been teaching myself, right? That's the Scolex. The second thing, Professor Mohan always talks about that, look at the signal of these cavities, right? Are they suppressing or not, right? In many tumors, in most tumors, tumor-associated cysts usually will not suppress, right? In this case, this was completely suppressed. And look, this is very similar to that of CSF, right? So I think these two findings and all this cluster of cysts in this Scolex should be able to make the right diagnosis of cystosarcosis. Final case, right? Now you have very large, right, sharply circumscribed cystic lesion. And notice that there are some of these, things that are kind of projecting from the wall, but notice they're not enhancing, they're not restricting, right? So this is not a fungal abscess, right? Not a fungal abscess. And these cyst contents, they actually also suppressed on flare. And when you did spectroscopy, you saw succinate. And again, another example that you're dealing with a parasitic cyst. And this is the actual pathology specimen of this case. And another case that was actually a hydatid cyst, right? And, I'm just showing you this video that I downloaded this morning, that this is how you remove hydatid cysts from the brain. And this is called hydrodissection. Thank you all very, very much. And now in the last 5 or 6 minutes, I would ask Michael to maybe show a few cases from our paper. And then if you are interested, then he's happy to send you all a copy of that. Thank you all.
Thank you very much, Dr. Mohan, for the wonderful introduction. And thank you, Dr. Marmourian, for the opportunity to speak with everyone today about some additional cases to illustrate CNS infections. So we're both at the University of Pennsylvania. These are some 6 themes that we'll discuss in addition to what Dr. Mohan has already very nicely illustrated. So our first patient is presenting with ear pain and headache. So we can see on the CT scan, there's asymmetry already of the mastoid air cells. There's opacification of the mastoid space, specifically on the right. And then when we look at the MRI, there's this well-circumcised lesion that's flare hyperintense with some perilesional edema. And then interestingly, there's no major diffusion restriction that we would see on the DWI. The case gets more interesting because—
Michael, can I point out one other finding if you go back to the previous CT? So again, one thing that I've always said, that if you have opacified mastoids, if you have increased tissue in the external auditory canal, right? If you have areas of bone erosion, bone destruction around them, you think about complications of mastoiditis. You think about infection extending to the skull base osteomyelitis, right? And the earliest imaging finding of skull base osteomyelitis is asymmetric effacement of the retrocondylar fat pad. And notice that the condyle in this case, on the right side, the mandibular condyle on CT appears to be pushed forwards, right? And if you see the soft tissue windows, you will see that the retrocondylar fat is actually effaced, right? So if you see that sign, then should make you all very, very worried that in this patient, infection is actually spreading to the skull base and causing skull base osteomyelitis. And then you start looking for all these other complications of skull base osteo.
Absolutely. Yeah, so definitely worried about mastoiditis and now the additional complications of mastoiditis. So we see something in the brain parenchyma. We notice that that same lesion that was flare hyperintense has some, peripheral enhancement as well. And then very strikingly, in addition to the enhancement of the mastoid space, we see adjacently, there's substantial enhancement in the sinus. So CT venogram 3D reconstruction demonstrates this obliteration of flow in the transverse sinus on the right, which would be in this person with mastoiditis consistent with complications including cerebritis and venous sinus thrombosis, as well as thrombophlebitis. Our next case is a neurosurgical patient who presented with seizures. So they initially came in with a headache. MRI showed that they had this low-grade glioma abutting the left frontal horn, and this was resected by neurosurgery. Here's the one-day post-op image, and the resection cavity looks fair. And then 2 months later, the patient has a seizure and comes into the ED, and repeat MRI demonstrates enhancement of the resection cavity. Moreover, you can see at different level, T1 post-contrast MRI shows enhancement of the pendymal lining consistent with ependymitis, and then diffusion restriction substantially in the lateral ventricle on the left. So this would be concerning for somebody who had neurosurgery, post-operative complications with abscess in the resection cavity, as well as ventriculitis. Our next case is a patient who's presenting with a headache in a young adult male with a history of frequent respiratory tract infections. So just keep that in the back of your head for possible rare disorders. So this person, you can see diffusion-weighted imaging demonstrates this diffusion restriction in this lesion, as well as peripheral enhancement as seen on this T1 post-contrast coronal MRI. So we're concerned for, could this be abscess? Other things that are known to cause ring enhancement, we talked about glioma, we talked about other types of neoplasms. And one way we can help distinguish between, in addition to the diffusion sequences, but one way that we can help distinguish between and make us more confident between infection and neoplasm is what's called the dual rim sign, which was discussed in this 2012 paper in AJNR. And the dual rim sign is very specific and very sensitive for abscess. It's not seen in glioma. And on the T2 weighted sequence, you can see that there is the presence of these concentric rims. So there is a T2 hypointense exterior rim separating the perilesional edema and the abscess capsule. And then there's a T2 hyperintense ring that shows the capsule. And then sometimes you can make out possibly even a third rim, which is additionally T2 hypointense before you get into the abscess cavity. So this dual rim sign was present in this patient, which is more suggestive of an abscess. And when you take this kind of into consideration with their picture of frequent respiratory tract infections, we further see that they have, on the left, chronic maxillary sinus disease, and notice those mastoid air spaces again, they are underdeveloped. And here is the smoking gun in this particular person, this chest x-ray. You're reading it right. This is actually on the right. This is not a flipped chest x-ray. This person has very glaring dextrocardia. So you can see the cardiac border. You can even see the gastric bubble. So this is not just dextrocardia, but this is in fact situs inversus totalis, so which is very, very classic for a specific and rare
recording in progress
called primary ciliary dyskinesia or Cartagner syndrome. And this is caused by a mutation in the dynein protein that's important for ciliary function. So that's important in regulation of the sinuses and clearing out mucus. That can lead to local infection and invasion into the brain parenchyma. And it's also very important for patterning of left-right body direction. So that's what we see here. Now we're going to talk a little bit about some sequelae of meningitis. So this person presents with acute onset of stiff neck, so nuchal rigidity. We're immediately worried about meningitis. They also have some signs concerning for additional neurologic deficits, so facial weakness, and fixed dilated pupils. We're already worried about facial nerve. We're worried about cranial nerves 3, 4, and 6. So T1 post-contrast MRI shows, again, ependymal lining enhancement. And then also we see enhancement of the cranial nerves. So we know if there's enhancement of the cranial nerves, that is always pathologic. So here we see trigeminal nerve bilaterally. We see facial nerve, vestibulocochlear nerve, also demonstrated on the axials. And then cranial nerves 9 and 10. So glossopharyngeal and vagus. This is most consistent with somebody who has bacterial leptomeningitis with multiple cranial neuropathies as a complication. Some additional sequelae. Here's a patient who's immunocompromised. They have HIV. They're presenting with left-sided headaches. So here we see what looks like a ring-enhancing lesion. And then additionally, CTA was performed. You can see irregularity of the vessel thickness. So here's the MCA. At M1, there's some focal beading as well as some focal stenosis in M2, some additional irregularities in proximal M3. This is concerning for vasculitis. And when we put this together with somebody who has a ring-enhancing lesion, somebody who has HIV and is immunocompromised, CSF studies were sent, additional serum studies were sent. This person was positive for TB. And they had tuberculous meningitis. This is a tuberculoma. And it's right adjacent to vasculitis. So in this case, the tuberculoma is inciting inflammation of the vessel walls, leading to vasculitis. And then one more sequelae of meningitis. This person is also immunocompromised and they present with confusion, altered mental status. And as Dr. Mohan mentioned, there's, in his case, when you're worried, when you see basal ganglia, the perivascular spaces near the basal ganglia that have enhancement, it can be asymmetric, it can be symmetric. There's a little bit of associated diffusion restriction. You're worried about something like cryptococcosis. You can see here that there's also very marked diffusion restriction in the splenium of the core callosum. This is actually an infarct. So cryptococcosis, cryptococcal meningitis, cryptococcomas, they're associated with vascular abnormalities as well and can lead to infarcts. And then we'll just briefly touch upon some atypical CNS infections. I think both of these cases are actually very similar in that it's a patient who has acute myeloid leukemia. So they have some sort of liquid neoplasm. They're given bone marrow transplant, and then they develop graft versus host disease. So they have to be on chronic immunosuppression. So they're given prophylactic antimicrobials, voriconazole, antibiotics. But unfortunately, this gentleman develops acute visual field deficit. So right inferior quadrantopia, that's field cut in the right inferior quadrant, which localizes neurologically, if you go back to your med school days, to the left superior optic radiations, so where you would expect to see in the temporal and occipital lobe. And that's exactly what we see on the MRI. Flare hyperintensities, it's also seen on T2, and ring enhancing lesions as well. This gentleman had brain biopsy because it was still unclear after the MRS and additional imaging what this was. And this ended up showing aspergillosis. He was started on amphotericin, but unfortunately did end up passing away several weeks later. Very similar case of another person with AML, graft versus host disease, chronic immunosuppression. Here you see this classic finding of multiloculated, multiple ring enhancing or peripherally enhancing lesions that are overlapping that demonstrate diffusion restriction. So this is classic finding for nocardiosis. And then one more for atypical CNS infections, flare hyperintense lesions, these eccentric target signs that Dr. Mohan was mentioning, shown by the arrows. And then interestingly, normally we think of abscess, somebody with HIV, altered mental status, you think of diffusion restriction. In this case, we don't see diffusion restriction. So this is an example of classic toxoplasmosis in a patient with HIV. And then very briefly, I'll end on some additional words and illustrative cases on pachymeningeal enhancement. When we think of meningitis, we think of leptomeningitis involving the pia and the arachnoid. Pachymeningeal enhancement is often thicker, involves the dura mater. It can be seen in both infectious as well as inflammatory and non-infectious causes, as evident here on this table. So our first case, this person has a known rheumatologic disorder, and they have a sudden onset thunderclap headache. T1 post-contrast MRI demonstrates thick areas of pachymeningeal enhancement, both in the anterior and posterior falx. And 3D reconstruction of the CT venogram demonstrates obliteration of flow in several different dural venous sinuses. So pachymeningeal enhancement in the anterior falx corresponds to lack of flow in the superior sagittal sinus, and then in the posterior falx, corresponding to right transverse sinus. You can see patent left transverse, patent inferior sagittal sinus, great vein of Galen, basal veins of Rosenthal, but these are deficits there, which are consistent with this person had pachymeningitis due to their known granulomatosis with polyangiitis, also known as Wegener's granulomatosis. Pachymeningitis incited inflammation leading to venous sinus thrombosis. And then two companion cases, both involving ophthalmic and orbital pathologies. So this is a middle-aged gentleman who had vision loss acutely that was painless. And you can see pachymeningeal enhancement involving the cavernous sinus and the optic nerve. This person with painless vision loss ended up having idiopathic hypertrophic meningitis. Compare that to this companion case, also pachymeningeal enhancement. This person with proptosis of the right eye, as well as sudden onset of ophthalmoplegia, so palsy, as well as double vision, and really substantial, exquisite periorbital pain. And they ended up having, see here, pachymeningeal enhancement of the anterior temporal lobe around the middle cranial fossa, as well as the orbital apex, things on the differential, cavernous sinus thrombosis, orbital apex syndrome. But if you have these imaging findings with the clinical constellation, that is this very rare disorder, Tolosa-Hunt syndrome. So if you see something like this, painful, Tolosa-Hunt. If it's not painful, think idiopathic hypertrophic meningitis. And if you're interested for more clinical cases, please read our article in the February 2023 issue of Neuroimaging Clinics. Thank you.
Excellent. Thank you, Michael. Any questions, comments, anyone, anything that is unclear?
Well, I just want to thank you, Soyesh, and also Michael for that excellent talk. And I think it highlights an aspect of neuroradiology that has always kept me engaged in practice, is that these are obviously not cases that you can reach a diagnosis by just looking at one or two pulse sequence, sort of what we used to call gunslinger radiology, where you say, well, that looks like metastatic disease, or that looks like a glioma. These are more on the level of like Sherlock Holmes cases, where you have to tie together the history, you have to tie together all of the imaging sequences, and also sometimes the CT findings. So thank you very much. That was really a sort of an exquisite display of some rare pathology. But of course, in terms of the practice of neuroradiology, we're really not providing value by just saying, oh, that's a stroke, that's a tumor. I mean, I think it's these high-level diagnoses that are, that's the added value of the neuroradiologist, is to be able to bring these into play and diagnose appropriately. And of course, from a patient point of view, these are critical distinctions in terms of the treatment avenues. So thank you both very much, and thank you all for your attendance.